Welcome. We have a beautiful program called Prevention and Management of Heart Disease in Type 2 diabetic patients. And we have two famous experts with us tonight, and we will learn a lot from them. It's always a pleasure to have diabetologists along with cardiologists, because every time we listen to diabetologists as cardiologists, we learn a lot, and it may be true also in the reverse order. So it's my great pleasure to say that we have tonight Professor Peter Grant, a diabetologist, a good friend, and I always learn a lot when I listen to Peter, and he will start this program, and we will follow with Professor De Ferrari, who is a cardiologist from Torino in Italy. So Peter, you have the floor.
Thank you for that very kind introduction. It's a great pleasure to be here. We're living in a spectacular time in the management of type 2 diabetes, which has markedly changed attitudes within the diabetes spectrum, but I think also over the last 5 years has changed cardiovascular disease and renal management as well. And I'm going to give us a talk that takes us through some of the history that's led up to the novel diabetes managements that we're currently going to talk about. So I'd like to start by having a question. Is glycemic control the most important factor in heart disease? Simple binary question, yes or no. So 47% say yes, 53% say no. That's a pretty even split across that question. So let's have a look at what the data tells us. Well, I think it's fair to say that for the last 70 years or so, most diabetologists have focused on glycemia as the main driver for the development of cardiovascular disease, people with diabetes. But the first trial carried out to look at this issue was called the UDGP, carried out in America. And the leader was a man called Dr. Goldner. And he said that the results from this study have given little hope thus far that the cardiovascular complications of diabetes are preventable by simple control of blood sugar. Neither insulin nor hypoglycemic agents gave greater protection for this condition. So this was in 1971, 50 years ago. And since then, we've spent a lot of time and money trying to find out whether this statement is correct or not. Let's have a look at the risk of cardiovascular disease, mainly in relation to the development of renal disease. And you can see here, as you look across this slide, you see that if you look at all patients with diabetes, there's about a threefold increased risk of cardiovascular disease. Healthy diabetes patients who merely have hyperglycemia, however, without renal disease, have a very small increase in cardiovascular disease, 1.3 times. So the majority of the risk for cardiovascular disease doesn't actually preside with diabetes itself, with the metabolic consequences of glycemia. As you move across to the development of albuminuria and a lowered EGFR, we get a 6 to 8-fold increase in cardiovascular disease. So these data are suggesting that the really important issue is renal disease. And when both are occurring together, and when you end up with chronic kidney disease and chronic renal impairment, there's as high an increased risk as 40-fold in patients with diabetes. So there's a number of issues here that are suggesting maybe glycemia isn't really the most important factor in developing cardiovascular disease. Maybe it's actually the relationship with the kidney, and I'll come back to that a little later on. But let's carry on thinking about glycemia for now. The major study that was presented in relation to type 1 diabetes and glycemic control was called DCCT, which reported in the 1980s. And if you look at the top of this slide here, you can see the HbA1c in a group of patients who are given intensive treatment with insulin, and they dropped from an average of about 8.7% down to 7% and was sustained there for 9 years. And the conventional treatment stayed along at what we now think of as being very poor diabetes control with an HbA1c of 9%. The trial was stopped after 10 years at the dotted line that you can see here, and the two lines came together after that time. What we saw from this data was that if you looked at microvascular disease during this period of time in here, there was a marked reduction in particularly retinopathy in association with better glycemic control. But if you follow the dotted line down here and look at the prevalence of cardiovascular disease at 9 or 10 years, it's hardly had any impact at all. There is a beginning of separation of the two lines, as you can see here. And after 15 to 20 years, there's quite a marked difference. But this is the first set of data that said, well, glycemia does have an important role, but it's only really important over the longer period of time. It's not having an impact in the first 10 years. And of course, if you have people with acute coronary syndromes or with ischemic heart disease, and you think that you're going to change things radically with glucose control alone, that's probably not the case. If you look at type 2 diabetes patients, there's some interesting data in relation to cardiovascular disease and other complications. 4 studies shown here. What I'd like to point out is that UKPDS, the study on the top, carried out in the United Kingdom, that took newly diagnosed drug-naive patients. This is a critical issue. They improved their glycemic control with intensive treatment. They had a reduction in microvascular disease. Cardiovascular disease wasn't really affected very much in the shorter term, and mortality was the same. In ACCORD, ADVANCE and VADT, which were longer duration diabetes, who started out here, you can see 10 years, 8 years, 11 and a half years, they had a reduction in microvascular disease, no change in mortality, except for ACCORD, which had increased cardiovascular mortality, which was a problem. Obviously a problem. If you move on and look at the longer term picture, you can see that there is actually changes in cardiovascular disease over the longer term again for in the UKPDS study, not so much for those who had long-standing diabetes. So there's 2 things that are shown here really, that in newly diagnosed diabetes, if you attack the glucose early, you get benefits in the cardiovascular arena, which don't appear if you leave them to treat much later. And you're going to have to get much better control over that period of time. So both studies seem to show, both in type 1 and type 2, glucose is important, but only in the longer term, and started early when patients are young, and you will get benefits much later in life. So if that's the case, what is the most significant risk factor for cardiovascular disease in diabetes? After things I've said, is it dyslipidemia, obesity, hyperglycemia, thrombotic risk, or none of the above? Okay, so 24% say dyslipidemia, 20% obesity. It's pretty well split. Hyperglycemia, 33%. I've not convinced you about hyperglycemia. I can see that. Thrombotic risk, 9%, despite the fact that thrombosis is the terminal event in acute coronary syndromes. It's only 9%, and none of the above, 12%. Now, I want you to hold your answers to that question, because what I'm going to tell you in explanation of the answer is going to be taking place over several slides. But my view is that the top 4 all have important roles, but actually renal disease is the real issue. And so I would say, in some senses, none of the above, although everybody would recognize they are important risk factors. But from the early data I showed, renal disease is the most important factor. So let's go on. Well, type 2 diabetes has been characterized metabolically by this slide, really, which shows how insulin resistance develops in relation to obesity, shown here, a red line here showing insulin resistance occurring. And in relation to that, insulin levels increase to keep postprandial and fasting glucoses in the normal range. So up to time 0, we have a period of 10 to 20 years when people have euglycemic insulin resistance, but they're moving towards the development of type 2 diabetes, what happens that causes the development of type 2 diabetes is the pancreas can't sustain this level of insulin indefinitely. It gets worn out, insulin levels drop away, insulin resistance stays the same, and glucose levels go north. So that is the full-blown picture of type 2 diabetes. And in this scenario, the macrovascular complications, which we're talking about today, start during insulin resistance itself, euglycemic insulin resistance, and I'll explain why. And the microvascular complications start as the blood glucose rises into the abnormal levels. So these are two different things, but microvascular complications at the same time get worse during that period of time. In a temporal way, there are two different things happening. Macrovascular disease early in the course of insulin resistance, microvascular complications later. Why is that happening like that? Well, the great clinician scientist Gerald Reaven tried to explain this by suggesting that insulin resistance itself, shown here, associated with obesity, cause clustering of atheromatous risk. These factors that he identified were hypertension, hyperglycemia, increased insulin, and changes in the lipid profile with increased triglyceride. Well, at the same time, it's been shown, whilst that is true, it's been shown that there are also changes in the cellular and circulating components of the inflammatory process, and in the cellular and circulating components of hemostasis, of thrombosis, shown here. So we get increased monocyte activity, increased CRP on this side, and over on the coagulation side, hyperactive platelets, which increase thrombosis, increased levels of the protein pi1, which prevents the breakdown of the fibrin clot here. And this creates an insulin resistance as an inflammatory atherothrombotic syndrome, which causes an increase in cardiovascular risk. So this is part of the reason why there's a 2 to 3-fold increase in cardiovascular disease risk in diabetes patients with insulin resistance. And many of these features are present before the development of diabetes. So it's a very long process leading to increased risk when diabetes finally occurs. Now, what evidence is that this works as such, as that? Well, there is evidence that if you manage the risk factor clustering effectively, you can reduce the risk of cardiovascular disease. Metformin, for example, is a drug which has always been thought to reduce insulin resistance and has effects on some of the components of the inflammatory atherothrombotic syndrome that I've just described. This data on the left-hand side is from the United Kingdom prospective diabetes study and shows outcomes over a 15-year period in patients treated with metformin in the light green color, intensively in the red line, and conventional therapy in the blue. And you can see there's a reduction in cardiovascular risk in this study with a significance equal to p equals 0.01. This actually carries on much longer as well, as shown on the right-hand side. But I'd just like to draw your attention to the number of people involved in this study, 342 treated with metformin with only 39 events. So there is a question mark as to how applicable this data is to the modern world of diabetes. It led to metformin being first-line treatment for a very long time, but maybe that's changing a little bit now. So that's one bit of evidence that treating the insulin resistance syndrome might be beneficial. But really, the best piece of evidence comes from STEAN-02, which is a trial of intensive management of multiple risk factors in high-risk patients with renal disease. So it's small numbers of patients, but very high risk. And this trial was carried out over 15 years or so in total. And their cholesterol and blood pressure, glycemia, and aspirin therapy was intensively followed in this treatment group, and the other group was treated what was conventional at the time. You can see that there is a marked divergence of outcomes in the patients who are treated intensively in this way. And what is so different from the glycemic story is that you're seeing a benefit occurring in the first couple of years of managing patients intensively, and that's carrying on up to 15 to 20 years. With glycemia, we didn't see any differences until about this period of time with intensive treatment. So this is an argument for managing all of the risk factors that I've talked to you about. However, if you look at what actually happens in diabetes, it's very different from this theory that I'm talking about. So this is a study from Leicester, which is a meta-analysis of 370,000 individuals' data from 24 countries, 24 studies rather. And they were looking at the ADA targets for HbA1c, blood pressure, LDL and HDL. And these are terrible figures really, because they showed 43% achieved the HbA1c target, 29% the blood pressure, 50% had LDL to goal, that's pretty good, 58% achieved the HDL goal, and there was no change year on year. So people were getting to a certain level, which wasn't a good level, and then staying there. And this is not good data from the point of view of hoping to improve cardiovascular outcomes in people with diabetes. So it's very important that we get to the point where we are treating multiple risk factors, and we should be treating people intensively from an early stage in order to get maximal benefit. So let's go back to this picture again, the impact of kidney disease in type 2 diabetes. There's all diabetes on the left-hand side, no kidney problems, which I've talked about, and this exponential increase as you move from albuminuria through to chronic renal impairment. That's become one of the major features of diabetes care, really, in the last 5 years, which has come along in concert with the new therapies, which have shown major effects on these organ systems. So we now think about hyperglycemia being accompanied by this end organ damage, which is affecting the heart and the kidneys, and that the three systems, diabetes, the metabolic processes of diabetes, heart disease and renal disease, are interacting with each other to massively increase cardiovascular risk. There has been relatively little that we can do about renal disease. Control of blood pressure is one thing, and new drugs are coming out that affect that. There have been big advances in heart disease, but of course there's still residual risk in heart disease, and diabetes patients are still dying prematurely because of the effects of diabetes on these processes. So we need something that's going to change and break into this triad and help our patients to live better, healthier lives. So the new diabetes therapies, just to tell you what I'm going to talk about, in the incretin system, there's GLP-1, and GLP-1 is a hormone that's released by the gut and which has effects, three types of effects. On the brain, it causes satiety. On the pancreas, it increases insulin resistance, and it slows gastric emptying to increase satiety at the GI level as well. DPP-4 is an enzyme which breaks down GLP-1. So another set of drugs that are available are DPP-4 inhibitors, which increase the half-life of GLP-1, thus having major effects on these processes. But this increases the GLP-1 life of endogenous GLP-1, whereas GLP-1 by either orally or by injection can obviously cause much greater increases in GLP-1 in the circulation. On the SGLT2 side of things, the SGLT2 is an ion channel, and the inhibitor inhibits the ion channel to cause increased glucose excretion and a mild loss of sodium, which has beneficial effects on glycemic control, but also has beneficial effects on the afferent blood flow from the glomerulus, tending to lower the pressure in the glomerulus and leading to a normalization of renal function in those circumstances. So that's a major part of the effects of the SGLT2 inhibitors. I'm going to start with the incretin system, though, and talk a little bit about what we know about those effects on cardiovascular disease. Well, here's a summary of the first cardiovascular outcome trials with the newer type 2 diabetes agents. We've got 3 agents here, which are DPP-4 inhibitors, all oral DPP-4 inhibitors, and this is a GLP-1 analog on the bottom. So these trials, I think it's important to say that these trials and the early trials with SGLT2 inhibitors were all safety trials. They weren't designed with the opportunity to give answers about whether cardiovascular disease itself was prevented or whether they affected the kidney, etc. So all of the early trials where we see cardiovascular outcomes and renal outcomes, they are really secondary outcomes, and they've led to the need for further studies with these outcomes as primary outcomes. But if we look at saxagliptin, alogliptin, and sitagliptin, this was very tedious. They were all completely negative. They weren't harmful from a cardiovascular point of view, but they all were negative from a beneficial point of view. And in fact, the first GLP-1 agonist, lixisenatide, didn't show any benefit either. These are large studies, large numbers of patients involved in them, some with acute coronary syndrome, large numbers of ischemic heart disease in all of them, and yet it didn't seem to do very much from a beneficial point of view. In addition, the DPP-4 inhibitors are rather weak glycemic agents, so their role in diabetes care has not really been very powerful. But let's look at what's happened with the GLP-1 receptor agonists, because that story developed over a period of time. And we can see here 5 outcome studies with GLP receptor agonists looking at a 3-point MACE endpoint. I have to say again, these studies weren't designed to look at these endpoints, but they're a post hoc analysis in effect, which is a criticism, but I'll show you some other data later to support what I'm showing you. So 3-point MACE, this is liraglutide in leader, this is semaglutide, we've got dulaglutide, and over here there's oral semaglutide. All of them are showing a beneficial effect on the 3-point MACE over a sustained period of time. And again, these changes are occurring relatively early compared to the effects of glycemia. So we can see here 104 weeks, 2 years here, and these lines are beginning to separate after 2 to 10 weeks after, and say it similarly here. So there's a relatively early effect of GLP-1 on 3-point MACE. If we look at altogether at a meta-analysis of 8 CVOTs and look at 3-point MACE again, this top part of the slide looks at those with a history of cardiovascular disease in these trials, and the bottom half is those with no history. And you can see there's clearly a beneficial effect of GLP-1 receptor agonists in these trials if you have a history of cardiovascular disease. Not so prominent in patients with no history of cardiovascular disease. So that's suggesting that this should really be a therapy in patients with established cardiovascular disease. If we look at cardiovascular mortality in these 8 trials, again, there's clear evidence that this GLP-1 receptor agonist reduce cardiovascular mortality. And on the right-hand side, as a group in the meta-analysis, they're reducing non-fatal stroke as well. So these are 2 very important issues. And what I'm showing you indicates that maybe the GLP-1 receptor agonists are having more of an effect on the atherothrombotic aspects of cardiovascular disease than the cardiac muscle aspects of cardiovascular disease, if you like. So there's another question here. GLP-1 agonists improve renal function. Is that true or is that false? So I'm postulating that maybe these are drugs that affect atherothrombotic disease rather than muscular disease. What will they do here to the kidney? Okay, 67% say that's true, 33% say that's false. It's probably fair to say that both groups have a point, and I'll explain why. So here are renal endpoints, and this is hard renal endpoints. This is macroalbuminuria on the right, but the hard renal endpoints include albuminuria, and it seems to be that there is a beneficial effect on albuminuria, as you can see on the right-hand side over here, overall. And that seems to be driving most of the hard renal endpoints. So it's not entirely clear that we're seeing major effects on EGFR, but we are seeing effects on macroalbuminuria, and that in itself should be a beneficial effect in terms of final renal outcome. So I think I would say it is beneficial on renal endpoints in people with diabetes treated with these drugs, but it's not as glaringly obvious as the beneficial effects on cardiovascular disease. So next we came along to the SGLT2 inhibitors. And I have to say that we nearly all fell off our chairs when we saw the results from the empagliflozin study, EMPA-REG, and its effects on cardiovascular outcomes, because we had sat through myriad presentations hearing that drugs didn't make any difference to cardiovascular disease or diabetes therapies didn't. And then this came along. So this is EMPA-REG, empagliflozin in blue, placebo in grey, other normal treatment otherwise as a background. You can see 3-point MACE, all-cause mortality, cardiovascular death, hospitalization for heart failure. They're all showing beneficial effects on outcome. And this was a staggering study at the time, and it's really driven a lot of the subsequent work that's being carried out in the SGLT2 inhibitor arena. And it really puts, it throws something out into the medical arena that says we've got to find out whether this is true or not. Because remember, this is a safety study essentially, but all of these results are coming out indicating that it's had a major effect on cardiovascular outcome. So it's not just safe, it's actually superior as well. So that was published in 2015, just 8 years ago. And since then, we've had a whole raft of SGLT2 inhibitor studies. And I'm just going to show you the first three that came out. This is 3-point MACE, again, with EMPA-REG outcome, the CANVAS program, which is canagliflozin, and DECLARE, which is dapagliflozin. And you can see that all of them have demonstrated a benefit in terms of 3-point MACE over a 4-year period. On this case, 6 years over here. And it's clear that there seems to be some beneficial effect on cardiovascular outcome on 3-point MACE with SGLT2 inhibitors. When this data started to appear, of course, it raised major questions as to what's it doing, because the SGLT2 ion channel is in the kidney and it's not really seen in the heart. The SGLT1 is, I think, present in the heart, but not 2. So it was very much raised as to what was happening here. So if we looked at various other outcomes, SGLT2 inhibitors' effects on hospitalization for heart failure and cardiovascular death, you can see, again, there's all these beneficial effects falling out in these early studies over a period of time, with quite marked separation of outcomes in patients treated with these drugs compared to placebo. So we've beneficial effects on heart failure, particularly, also 3-point MACE. SGLT2, do they cause an initial fall in EGFR and subsequent renal function stabilization? Is that true or is that false? So 76% of you say that's true, 24% say that's false. Well, I think the answer to this question is unequivocally that it is true. And I'll show you the data. Here's the EMPA-REG data showing 2 different doses of empagliflozin, which were used in this trial. And you can see here there's an initial fall in EGFR with the use of the SGLT2 inhibitor and subsequent pretty much stabilization of the EGFR, where the placebo group is just inexorably falling. And after 2 or 3 years, you're getting quite a marked difference in EGFR. These are really outstanding results, but again, it wasn't the primary outcome of the study, and we need to just look at whether that's actually real or whether it's just been thrown up by chance, improbable as it seems. So the meta-analysis of the studies I've just talked about, 34,000 type 2 diabetes patients, 3,500 MACE, 2,000 cardiovascular deaths, etc. In the whole group, MACE was reduced by 11%, shown here, which was significant, but that benefit was only seen in those with established atherothrombotic cardiovascular disease. Cardiovascular death and hospitalization for heart failure was reduced by 23%, and that was seen in those both with and without heart failure. Renal disease progression was reduced by 45%, which is a stunning finding, and the effects were greater in those with less severe impairment. So, indications for the use of those drugs in people with diabetes will come. But let's just have a look at a couple of studies where the primary outcome was either renal disease or heart disease and see what we saw as confirm the findings in the earlier studies that I've showed you. This is Credence, the effects of canagliflozin on the primary renal outcome in type 2 diabetes over 3 years. And you can see the primary outcome shown in red here, end-stage renal disease, doubling of the serum creatinine or renal or cardiovascular death. And canagliflozin showed a marked improvement in outcome over a 3 to 4 year period in patients with diabetes and renal disease. So that was a stunning study, really, a major outcome confirming a drug that could be used in diabetes for improving cardiovascular outcome. Here's the data from that study on albumin-creatinine ratio, improved with canagliflozin, sustained improvement over a 3 to 4 year period of time, and the same sort of picture of the estimated glomerular filtration rate, showing an initial fall in that value, followed by stabilization over a period of time. So this is very important data, as renal impairment is one of the major reasons why our patients get severe cardiovascular disease. If we go back to empagliflozin, you can see that this is a study in heart failure called EMPEROR-Reduced. It's in patients with systolic heart failure who have a reduced ejection fraction down to 20 or 40%. The primary outcome here, cardiovascular death, it shows that you have an improvement with empagliflozin compared to placebo in heart failure. You have first and recurrent hospitalizations, an improvement in hospitalizations for heart failure over this period of time. And this is the renal outcomes in this study, which show improvements as well. So empagliflozin given to patients with heart failure as a primary outcome show marked improvements in outcome to confirm the early studies with that drug. And empagliflozin treated in chronic patients with chronic renal impairment, so this is putting renal disease as the first line output. It's called EMPA-Kidney. 6,000 subjects randomized to either empagliflozin or placebo, and they got the same sort of results. Again, EGFR 20 to 45 was the patients, and 2-year follow-up. Progression of CKD or death from CVD occurred in 13% compared to 16% of patients with a highly significant change. So these results have confirmed what we've shown. And I think it's important to just look at, finally, to just look at the interactions with other drugs, because there was a lot of worry in the diabetes community about whether giving these drugs would cause other problems in association with sulfonylureas and metformin, which were pretty much standard at that time. This shows those worries weren't something we should be worrying about. Down the bottom here, you'll see in all the studies I've mentioned high percentages of patients taking metformin. People would say, is it the metformin that's causing the benefit? Well, I don't think there's any evidence to support that view. And when you look at the hazard ratio of treatment of cardiovascular death and hospitalization for heart failure over here with SGLT2 inhibitors in the presence and absence of metformin, there's no difference in the presence of absence of sulfonylureas or insulin. There's no difference in outcomes. It's beneficial all the way through, and the same with hospitalization for heart failure. So these drugs look as though they're working independently of metformin. They are definitely having effects which are stronger than those seen with metformin. And I'll show you in just a minute what that means. Before I do that, I'd just like to look at a couple of other things. This is a study using SGLT2 inhibitors against sulfonylureas, and you can see a major benefit in terms of cardiovascular outcomes. So the drug works independently of conventional hypoglycemic agents in diabetes, which is a big benefit. And if we look at very briefly at this rather complex slide, which is showing the effects of therapies on heart failure in patients with reduced ejection fraction, you can see here, I only want to just show you that here is one, which means it's not having any effect. If we move across and up here, you can see that as you add an SGLT2 inhibitor shown next to angiotensin receptor neprilysin inhibitors, beta blockers, and MRA, you get an increased benefit with the addition of SGLT2 against the other therapeutic approaches. And that's true also, that's all-cause mortality. It's also true for mortality or heart failure hospitalization or specific cardiovascular mortality, where you see improvements being gained by the addition of SGLT2 inhibitors, which is suggesting that this should become one of the major players in heart failure management. And the evidence indicates also, which I haven't covered today, but the evidence also indicates that these effects are occurring whether patients have diabetes or have non-diabetes at the time of being managed. So I was privileged to do the ESC guidelines, to co-chair the ESC guidelines, and we came up with this concept for patients, newly diagnosed patients with diabetes who are on no drug therapy in the presence of coronary artery disease. They should be given SGLT2 inhibitors or GLP-1 receptor agonists as monotherapy. In the absence of cardiovascular disease, we tipped our hat at the metformin data and said that you could start with metformin. This caused an uproar. The diabetes community was pretty fixed at the time on the idea that metformin was always going to be first-line monotherapy. But actually, as the months have gone by, more and more groups have taken on this idea that it's important to be treating with this drug very early. And that's shown over here. I won't go through all these details, but if you look at the evidence for what I'm saying, this is the 3-point MACE endpoint with SGLT2 inhibitors. This is the 3-point MACE endpoint with GLP-1 receptor agonists. It's clear that it's having beneficial effects on that area, and it's clear that the SGLT2 inhibitors are having major effects on heart failure and renal disease as well. If we look at metformin over here, there's 390 patients with metformin, as opposed to something like 30,000 patients in these trials. And I'm still convinced that this is the right approach, that we should go for dual therapy very rapidly that can include metformin, but this should be considered first line for patients with cardiovascular disease and diabetes. So it's a compelling era at the present moment. If we look at the new therapies, we can have major beneficial effects on cardiovascular disease, renal disease, and improve not just longevity, but also the quality of life through these therapies. This slide is a way of saying what we should be doing, because I said much earlier, we're not actually applying the evidence to our diabetes patients. And if we have patients with diabetes and coronary artery disease, the therapy should comprise the management of the clustering of risk, which I talked about earlier on, antiplatelet therapy, LDL lowering, blood pressure lowering, glycemia, very important combinations to be improving the outcomes with our patients with diabetes. And sitting over here at last, some therapies which make our diabetes-related therapies, which make a major difference to outcomes with cardiovascular disease. Thank you very much for your attention.
Thank you very much, Peter. That was a brilliant tour de force. There are so many studies now with these new drugs, and clearly we have a clear idea of what's going on now in terms of management of these patients. We will take questions at the end of the two presentations, and without further ado, I would like to give the floor to Gaetano Maia de Ferrari from Torino about this other question, the coronary risk prevention in patients with type 2 diabetes. Gaetano?
So thank you, Gilles, and thank you to Peter for this wonderful presentation. So now, to try to engage you, I'd like to start directly with a question. So relative to your cardiovascular risk, what do you fear most? And actually, I propose having diabetes, having had a myocardial infarction, or both equally. So I will ask you in the next 15 seconds or so, please, to answer this question. Having had a myocardial infarction is the right answer, not necessarily a bad myocardial infarction, simply a myocardial infarction is okay. So both fear equally, if it's correct, the two conditions. Now let us see why this, where this is coming from, actually. And this is likely to be coming from one of the first studies, this by Hafner, who showed, as you can see here from the survival curves, that non-diabetics are here in gray, that diabetes with previous MI are in red, and that the two populations in the mean survival in between are exactly identical. They are composed by diabetics without prior MI and non-diabetics with a prior MI, so almost identical. And this is clearly shown in the bar graph here. As you can see, non-diabetic subjects have a 2.6% incidence per 100-person year of having a myocardial infarction. And this is, again, identical to diabetic patients with diabetes, as I should say, without prior myocardial infarction, as you can see here. And this is the incidence of cardiovascular death. Now, if we move to the next slide, which indicates fatal and non-fatal myocardial infarction, the picture is absolutely the same. Again, you see 3% for patients with prior MI and 3.2%, so exactly the same, for patients with diabetes and no prior MI. And actually, this type of concept was then confirmed by this study from 2005, which brings up the term of diabetes equivalent, as you can see here, indicating that, again, the incidence of coronary heart disease death is identical between patients with diabetes and no myocardial infarction as compared to patients with myocardial infarction and no diabetes. And of course, you have the two extremes in the bottom and in the top curve. So again, suggesting that the majority of you answered correctly this question. As a matter of fact, this was, of course, covered by the ATP guidelines, as you can see here, indicating that type 2 diabetes constitutes a coronary heart disease risk equivalent. Now, however, more recent data call a little bit into question this fact. You see this meta-analysis from 2009 indicating that overall, it appears that patients with diabetes on the left side, as compared to patients with prior MI, tend to have relatively less risk. In this case, as you can see, the odds ratio is 0.56, indicating overall, I believe it's with improvement in diabetes care, thanks to Professor Grant and his colleagues, indicating that progressively there is a reduction in the risk of patients with diabetes as compared to patients with a previous myocardial infarction. Now, this is also shown here. As you can see, for coronary death, for instance, you see that you have an incidence that is in a hazard ratio of only 0.12 in all participants, as compared to a hazard ratio for stroke of 0.66. And overall, in this additional analysis, meta-analysis, you have a hazard ratio for diabetics as compared to myocardial infarction patients of approximately 0.4. So suggesting that it may be better to have a diabetic condition as compared to have a previous myocardial infarction. So I would say the pendulum is swinging between the two, but I would rather now personally have diabetes, especially with the new drugs, as compared to having a myocardial infarction. So please take into account that I do believe that currently the prognosis is possibly better for this condition. So I would like now to pose you a second question. The new European Society of Cardiology guideline indicate a very high risk and an LDL goal of 55 for which type of patients? Answer A, diabetic with major risk factors such as smoking. B, diabetic with organ damage such as proteinuria. C, diabetes with 3 major risk factors. And then answer D includes both answer B and answer C. So the majority of you indicate the second plus the third option together. And indeed, I believe this is correct, because as you understand already know, there has been a change from the 2016 guidelines in which, as you can see here, diabetes with a major risk factor such as smoking was considered to pose a very high risk. On the other hand, in the current 2019 guidelines, you have the diabetic condition with target organ damage, or at least 3 major risk factors, early onset type 1 diabetes of long duration. So you actually need either organ damage or 3 major risk factors to be eligible for the very high risk condition. On the other hand, patients have diabetes and one single additional risk factor or a duration of more than 10 years are considered to be at high risk. So things have been changing, and very high risk patients are considered to be so if they have target organ damage or 3 major risk factors. And independently of the fact whether you consider diabetes a risk equivalent or not, it is still true that patients with diabetes have a markedly increased risk of cardiovascular and coronary disease specifically, and that 3 out of 4 deaths in patients with type 2 diabetes are of cardiovascular nature, and a great majority of this coronary. So this is still a big, big problem for our patients. And as you can see here, the duration of diabetes is a major player in this arena. As you can see, the duration from less than 2 years to more than 20 years increases prevalence by 3 times, from 13 to 34%. And this is the classical triple endpoint plus revascularizations. So we are aware, and the European Society of Cardiology guidelines take that into account. As you have just seen, they do consider the duration of the disease as a modifier of the risk from high risk to very high risk. The same is true for additional risk factors. As you see here, what is occurring with hypertension, diabetes, and the combination of hypertension for diabetes, as you see, has a very, very huge increase in rates of myocardial infarction per 1,000 patients, as indicated in this slide. So, how many years of life are lost due to a diagnosis of type 2 diabetes in a 50-year-old woman? And I give you some answers: 3 years, 4.5 years, 5.5 years, or 6.5 years. So if a person has the disadvantage of being diagnosed with type 2 diabetes at 50 years, will her or his life, in this case, her life, be shorter? And now, indeed, it will be shorter. So the majority of you clearly indicates between 4.5 and 5.5 years as the number of years lost because of a diagnosis of type 2 diabetes at age 50. As a matter of fact, what you do see here is the worst possible outcome I have mentioned. So take into account that if a woman is diagnosed diabetes at age 50, her reduction life expectancy is 6.5 years. So really a huge reduction. And as you see, the majority, 2/3 of this impressive life expectancy reduction is due to vascular disease. So we do need to act, and to act aggressively against this reduction in life expectancy due to a type 2 diabetes diagnosis. And of course, we have these new goals for lipids that you are very well aware, have just discussed. The 55 milligrams per deciliter for the majority of our diabetic patients, provided they do have target organ damage or established cardiovascular disease, or of course, 3 major risk factors, and then the very high risk, and then we have a high risk if they do have only 1 major risk factor. In addition, we have the prohibitive risk, which is the high risk category with recurrent cardiovascular events. These patients have an even tougher target to meet of 40 milligrams per deciliter. So very tough goals. And do we reach these goals? Well, of course, we should take into account that lipid lowering is not the only component. And this slide has been elegantly shown in a different way by Professor Grant. Of course, many factors contribute to this increase in cardiovascular disease, including physical inactivity, smoking, hypercoagulation, platelet activation, metabolic dysfunction, and so on. But still, dyslipidemia is a very major player in this topic and accounts for a very important component of this increased cardiovascular risk, which, as we see, reduces life expectancy in our patients. So how would you start treatment in your practice after PCI in a type 2 diabetic patients with an LDL of 96 milligrams per deciliter? So this is not an acute coronary event patient. It's simply a patient that had a PCI in a coronary artery. So would you start with atorvastatin 20, with rosuvastatin 20, with rosuvastatin 20 plus ezetimibe, or with a high-intensity statin plus a PCSK9 inhibitor? So this is nice to see. You see, we have a very equal distribution. So all 4 categories are being chosen with a very modest preference for rosuvastatin 20 milligrams plus ezetimibe. I would have personally also perhaps chosen this answer. And I believe there is an important aspect. First of all, statins per se often do not reduce the risk to the level of risk that have non-diabetic patients. This slide compares patients in trials. You see 6 major lipid-lowering trials, and you see the risk comparison of patients in placebo without diabetes, here on the left, and patients with diabetes but on active statin treatment. Invariably, patients with diabetes on active statin treatment have a markedly higher risk as compared to non-diabetic patients with placebo. So it is obvious that despite the fact they are effective, statin treatment does not by any means reduce the risk of diabetic patients to the level of patients without diabetes. Additionally, there is apparently a very important effect of ezetimibe. I had the opportunity to be in the steering committee of IMPROVE-IT, and one of the major findings with IMPROVE-IT was the fact that within the very long-term follow-up, as you can see, diabetic patients, these 2 lines, have a markedly higher incidence of major adverse cardiac events. You see almost 50% among diabetic patients during a 7-year follow-up. Now, this reduction was very marked as compared to the reduction in patients without diabetes. Especially if you look into the absolute risk reduction, this is a 5.5% absolute risk reduction, which translates is an NNT, a number needed to treat, of only 18 diabetic patients to prevent one major cardiovascular event with the addition of ezetimibe in the 7-year follow-up. Additionally, we know that remnant cholesterol plays a major role. Please look at this busy slide indicating that is in the large study, you have 2 goals, LDL and remnant cholesterol. And as you see, as compared to the reference population that is controlled for both risk factors, actually having remnant cholesterol, which is not controlled, is as bad almost as having both non-controlled risk factors. And higher postprandial triglyceride levels in type 2 diabetes. As you possibly know, diabetic patients are characterized, as you see in this slide, this orange curve, but a higher and more prolonged increase in triglyceride. And there is epidemiological data to indicate that this increase, both fasting and even postprandially, are associated with increased cardiovascular disease in patients with diabetes. And we have, as shown in this slide, the indication that ezetimibe, as compared to control, is capable of decreasing this postprandial increase in triglyceride, as you can see here very, very clearly. And this also, I will skip the middle part of the slide and show you only the bottom right part, indicate this is endothelial function. So not only this postprandial triglyceride are risky in general, but we can demonstrate that they derange the endothelial vasodilation. As you see here, this is clear in the blue curve and is remaining exactly the same after 4 weeks in the control group, whereas this postprandial derangement of endothelial function is actually markedly improved by ezetimibe. So it appears to be an additional benefit in diabetic patients provided by inhibition of absorption of cholesterol in the intestine by ezetimibe. So indeed, even this important publication by Kosh-Ray indicates that in patients at high risk or very high risk, in diabetic especially, the combination of statin plus ezetimibe should be considered the basic standard of care. So I would encourage you to consider indeed this combination as the basic standard of care for your diabetic patients, as well as a matter of fact for a patient with a previous myocardial infarction. Now, do we do well in this sense? Well, we don't do very well. I just want to show you one analysis we made from the TCOS trial, which is one of the trials which was shown to you by Professor Grant, a very empirical and pragmatic cardiovascular trial that was finished just a few years ago. And it indicates that there is still a poor control of LDL among diabetic patients. These were all diabetic patients with established cardiovascular disease. So they should have had 70 milligrams per deciliter or less with the previous guidelines and 55 or less with the new guidelines. Now, only 1 out of 3 patients met the previous guideline, and only 1 out of 7 patients met the current guidelines. And we have also seen whether in a multivariable corrected analysis, whether there was indication that there was a benefit during follow-up for starting the study with a lower LDL. And as you can see, there is a rather monotonic reduction, at least until the area of 50 milligrams per deciliter or 60 milligrams per deciliter in reduction. And every 10 milligram LDL cholesterol increase, there is an increase by 6% of cardiovascular death. So if you increase by 40 milligrams, for instance, from 55 to 95, you're expected to have, during the duration of the trial, a 24% increase in cardiovascular death. So a major, I would say, increase in risk. So let us go now to a clinical case to be more interactive. We are speaking of a young 34-year-old man, had a young onset diabetes, was a previous smoker with dyslipidemia, obesity, a CKD with a GFR with just at the verge of 60 milliliters per minute, personality disorders with psychiatric drugs, seizures, one of those young but complicated patients. He came to us with already a history of internal carotid artery stenosis. The treatment was pantoprazole, aspirin, bisoprolol, rosuvastatin, insulin for injection, and several neurological drugs. The presentation is a chronic angina, but with a progressively decreasing threshold. So worsening angina, LVEF 55% with a hypokinesia, negative troponin, not very well controlled glycemia, as you see here, 292. So a very poorly controlled, I think we can say. 7.8 hemoglobin A1C, LDL of 96, with aspecific repolarization abnormalities and incomplete right bundle branch block. So this patient, of course, is studied by us with coronary angiography. You see on the right coronary angiography 2 stenosis, proximal and the middle right coronary artery stenosis. You see a worse condition on an LAD. You see a proximal LAD, a middle LAD, and then a stenosis of this first diagonal branch. So we have a success score of 18. We discuss the strategy. This patient is very young, and we allow kidney protection. So we stop, we discuss with surgeon, the heart team, we discuss with the patient, and then, as you may expect, we proceed with PCI. So this is the direct stenting on the right coronary artery. On the left coronary artery, there is an IVUS-guided procedure with ostium nailing, with left main sparing and diagonal branch protection, as you can see here. And this is the final result. I think it's very satisfying on the right coronary artery, and I would say very satisfying on the left anterior descending coronary artery as well. So now, please help us in choosing the right treatment for this patient. 96 LDL on rosuvastatin 20, as you may remember, and all those risk factors that you have been seeing. So should we shift to atorvastatin 80, to rosuvastatin 40, that is, increase the statin intensity? Should we add to rosuvastatin 40 ezetimibe 10, or should we add to rosuvastatin 40 or 20 ezetimibe 10 and a PCSK9 inhibitor? So please help me in choosing what I should do in this case. So we have two main answers. One is to step up rosuvastatin and add ezetimibe, 46%, and shortly below that level, 38% suggest to add PCSK9 as well. And to tell you the truth, I would personally favor for this patient the answer D, and I will explain why. First of all, the patient has multivessel coronary artery disease. We know from this slide, from this Fourier sub-analysis, on the left, you have patients with multivessel disease, on the right, patient with single vessel coronary artery disease. You can appreciate the marked increase in absolute risk reduction with a very favorable NNT of 29 patients to treat, just to prevent one major, and this is the triple endpoint. It's not the extended 5 endpoint. It's the multiple 5 item endpoints. It's the triple endpoint of cardiovascular death and MI and stroke. So we know that diabetic patients benefit more. This is alirocumab in Odyssey outcome. As a matter of fact, identical relative risk reduction, but as you can appreciate here, double absolute risk reduction from 1.2 to 2.3 absolute risk reduction in MACE in the Odyssey study. Now, what about the Fourier? Now, in Fourier, we have seen that the reduction in LDL, first of all, is identical. If you don't have metabolic syndrome, or you do have metabolic syndrome, if you have diabetes or you do not have diabetes, so exactly the same reduction. But of course, diabetic is associated with a higher absolute risk. In this case, you see they are well-treated diabetics, so we have only an increase in 4 absolute points from 13 to 17% in the main endpoint of Fourier over the 3-year follow-up. However, clearly, the benefit is increased in patients with diabetes. Again, you see a 2.7 absolute risk reduction, which is translated into a 37 patients to be treated to prevent one major coronary event. And indeed, is it important to go very low? Well, I think with this triple therapy I was proposing to you, we will certainly lead to a level around 30 or 25 milligrams per deciliter starting from 96, no more than that. But actually, is this potentially useful? Yes. This relationship, again, from Fourier indicates there is continuous reduction in risk, no matter how low you are going, no matter how low level of LDL is attained. So indeed, it does push up to be very aggressive for this young patient. And we know that the earlier we start PCSK9, the better it is, because as you see, the first year, we reduced the event rate by 16%, but already the second year, the reduction is by 25%. So it's progressively increasing. And we have this new data that may be of interest to you if you haven't had the opportunity to look at them. This is long-term extension of Fourier, in which, as you can see, we start with this huge difference between, of course, evolocumab and placebo. But after both go into open label evolocumab, you see a 30 milligrams per deciliter or 0.75 millimole, equally identical in the two groups for the next 5 years. What does this translate into side effects? No side effects, no diabetes, no serious adverse event, no muscle-related event, no hemorrhagic stroke. So appears to be very reassuring in terms of safety. But I think interestingly, very interestingly, there is a decrease in the endpoint. So a 20% decrease, despite the fact that both groups are now taking evolocumab. Simply one group, the red group, was taking evolocumab also before, as compared to the gray line, which depicts a group that was previously taking placebo. So I think this is a very, very strong message, I believe. So please look into even a cardiovascular death reduction. You know that there was criticism over Fourier because there was no cardiovascular risk reduction, only of soft endpoints, if you want to put, although MI is not really a soft endpoint, but non-fatal endpoints. Now here, you see that you don't have this effect in the median Fourier follow-up, but this effect is present if you follow the patient longer on, even if you give evolocumab to both patients. So it is indeed extremely important to start early because the effects will build up. And even if you start later on, let's say after 3 years, you still miss a consistent part of the benefit, which is associated with early treatment with PCSK9 inhibitors. So one last question for you. Which of the following statements is wrong? And actually dinner is approaching, so please answer this very last question for me. The first is genetic variants reducing HGM co-reactives are associated with lower LDL and increased diabetic risk. Second, statin use is associated also with lower LDL and increased diabetic risk. Third, genetic variants reducing PCSK9 are associated with lower LDL, but increased diabetic risk. And finally, PCSK9 use is associated with lower LDL and increased diabetic risk. So one of these statements is wrong. So we have actually quite a mixed answer. I would not have thought that 44% of our colleagues thought that statin use is not associated with an increased diabetic risk. So perhaps Professor Grant has made a good argument indicating that you shouldn't take into account this very modest risk. But to my knowledge, the statin use is associated with an increased risk of diabetes, albeit it does not offset the great benefit of statins. Interestingly enough, Mendelian randomization studies indicated that both HMG co-reactase reduction is associated with increased diabetic risk, and PCSK9 reduction is associated with diabetic risk. But this was not found true for the treatment with PCSK9 inhibitor. And this indeed is my last slide, indicating that in the Fourier study, we published this in 2017 in Lancet Diabetes, there is absolutely no increase either in diabetic patients or in pre-diabetic patients in the incidence of overt diabetes in the beginning or throughout the years. You see, the hazard ratio for a patient with pre-diabetes, which should be the patient at higher risk, is exactly 1.00. Saying that indeed, despite the fact that diabetes is likely with current appropriate treatment to be slightly less dangerous than having had a previous myocardial infarction, still we lose 4 years just of life expectancy just for coronary and vascular events among a 50-year person who is being diagnosed with diabetes. So we need to be very aggressive for these patients. We need to control LDL very aggressively. We need to take into account high-intensity statins. We need to take into account ezetimibe. We need to take into account early on also the newer drug, such as PCSK9 inhibitors. Thank you for your patience up to now.
Thank you very much, Gaetano, for this very complete presentation. We have a few minutes for questions, so if we want to have a real effect on diabetes, we need to identify these patients very early. And we probably miss a lot of patients with diabetes. So, Peter, how could we do a better job in identifying diabetic patients early on, and not like what we see in the CCU too often, patients with an acute MI and a diabetes which has not been diagnosed for years? What shall we do?
Yes, well, I think one of the important issues is the prevention of diabetes, really. And there's strong evidence from the Daxing study from China that if you change lifestyle early on, you prevent both the development of microvascular complications and macrovascular complications, and indeed diabetes itself. So I think the first step is to say, can we impose better lifestyle on people than we have in the West, particularly at this time? And having done that, you look at people with family history of diabetes and see if they're at increased risk. You look at people who have obesity, which is a strong indicator of insulin resistance. And finally, I think nurses and doctors in general practice should be testing people for glycemia to make sure that they don't have diabetes, because all of the evidence says, as you've just intimated, that if you treat people early and intensively, they are far less likely to suffer the terrible consequences of diabetes.
Okay, so the answer is integration and detection.
Yep.
I think we have a case which has been submitted, and it's about lipids in a diabetic patient. Jose, go ahead, present your case rapidly, and we will ask the experts what to do with your patient.
Yeah, I present a patient with diabetes and hypertension with relative good control, but the problem with this patient is high levels of lipoprotein A, and what is the proper management of this patient? What do you think with the features I present in the slide?
If I understand correctly, we have an LDL which is not yet completely controlled, but we still have a lipoprotein A which is very high. Now, of course, as you know, there are currently few drugs that have a marked influence of lipoprotein A. And of course, currently, PCSK9 are perhaps the best drugs in terms of reduction, albeit they reduce lipoprotein A by 20 to 25%. So I believe that while waiting for interfering RNAs, which will be available in the, I would expect medium term, possibly not very short term, because we have still to see something about that. I would suggest for a patient like this, if eligible in terms of reimbursement, of course, to perhaps add PCSK9 inhibitor, because this would bring both the LDL to a target and would also allow a let's say, a reasonable reduction, albeit not a complete normalization of Lp(a) values. So I think this would be, from my point of view, the suggestion, of course, in addition to a high-intensity statin. This would be my suggestion for treating this patient.
Yes, and we would probably get a 20% reduction of lipoprotein A with PCSK9 inhibitor. Peter, we did not mention some of the side effects we may get with SGLT2 inhibitors, urogenital infections, for example. Is it a concern or no? Is it a trivial question because it never happens, or we should be careful and select the patient?
Clearly, there is an increased risk of urinary tract infections with these drugs, mainly because of the increased glycemia in the increased glucose rather in the urine. That in itself is not a serious side effect. There are also some ischemic effects that they can have, dermatological effects, but they're very rare. I suppose most of the issues have orientated around the possibility that there's an increased risk of euglycemic ketoacidosis, which has been reported with the SGLT2 inhibitors fairly commonly. But I think that it's not a serious concern. It's partly because beta-hydroxybutyric acid is increased in the plasma of patients with type 2 diabetes on SGLT2 inhibitors. And so there is a tendency towards producing ketone bodies.
Maybe a last question before dinner. It's the end of this program. Gaetano, what is your lower limit of eGFR to prescribe a SGLT2 inhibitor in your patients? We know it may be a difficulty that we have in our patients, especially in our heart failure patients.
Of course, if we stick with the current indications, we cannot give SGLT2 inhibitors of patients below 25 GFR. And this in general is what we keep on a regular basis of patients, but we do not interrupt the drug in case the GFR goes below this value. And I believe we need to increase our knowledge on what happens in patients below that. There are few, to my knowledge, limited data, I believe from the Mayo Clinic, suggesting that there may be beneficial effects even in patients with lower GFRs with no added risk. I believe in part, this comes from the history of the use of these drugs. And these drugs were used to lower glycemia by losing glucose in the urines. Of course, if you have a very small urinary output, you do not decrease glucose. So I believe that in part, this is because the way the drugs were developed is that they are ineffective against diabetes if you have a very limited urinary output. But the fact that they do preserve kidney function, I think, is, from my point of view, a strong indication that we should study even more this part with extreme renal dysfunction, because they possibly could benefit as well.
We have also a question on the chat, which says, what is the cause of this initial drop in eGFR with SGLT2 inhibitors? Do we understand why we have this drop, which is kind of scary in patients with low GFR to start off?
I don't think we really know what's doing this. It's a very similar change as is seen with the initiation of ACE inhibition, where you get a fall in the eGFR and then stabilization subsequently. They seem to, ACE inhibition and SGLT2 inhibition seems to have complementary effects, one on the efferent arteriole and the other on the afferent arteriole, which may be a part of the process is causing an initial change, which is deleterious. And then the glomerular function takes a little while to stabilize through the increased sodium excretion that's taking place and the changes in blood flow. I don't think we know specifically. I do think we need to know why it's happening, because I think it's not really clear why the SGLT2 inhibitors are having the effect that they are having. There's lots of hypotheses, but we could do with more information in that field, I think.
Okay, thank you very much, gentlemen. I think this program is coming to a close. Thank you, everybody. Bye-bye now.